Thrilled that you're all here. Jay, good to see you. I was all worried. I'm like, there's just three of us in this other room, and Jay's not here. Uh, I've been pumping this up a bunch, so I'm thrilled that everyone's here. Looks like we have a good group. I'm going to go ahead and quickly welcome you all. I don't know what Jakaria said, but thank you. This is our Stanford Community of Improvement Professionals. So this is our opportunity to come together amongst those interested in improvement, improvers in general who are either at Stanford or affiliated with Stanford somehow, either taking a course with us or participating in our Stanford Medicine Center for Improvement. Any touch point within Stanford, you're welcome here. Even if you don't, you're welcome here, because this is an opportunity for all of us to connect, to network, to say hi to one another, to see who else in this world is interested in improvement. And today we have a great opportunity to hear from someone who's been doing this much longer than me, and who is so interested in some of these skills and concepts that he took it upon himself to create software that many of us use for statistical process control or Shewhart Charts, and also has written, Jay, I've counted at least 3 books, maybe a 4th, that he's written on this topic. He's passionate about this. He can talk about it and does talk about it all the time. If you sign up for his newsletter, you get into his brain a little bit. Every week, you get these little insights from him. It's really fun. So I'm going to go ahead and postpone our time of networking and connecting to the end, so that we have an opportunity to maximize the time to hear from Jay, have questions, and then at the end, what we're going to do is what we normally do at the beginning, and that's a connection point where we can discuss the topics, the concepts, and then also have a chance to get to know each other. Let me also, before I jump in to share with Jay, I do want to highlight a few things with the Center for Improvement. So one is our new website. Our new website, we have the main focus we have, or one of the things I'd like to highlight for most everybody, is the toolkit. We have tools that you can use to access any sorts of information, videos, etc., on our website. We also have events page where you can learn about our upcoming quality symposium in May, our improvement healthcare academic conference coming up in September on the 10th and 11th, all sorts of things, as well as our courses. So check that out for sure. And you also, for those who have done improvement work, and actually building on what Jay's going to talk about today, we have an opportunity to present posters of some of your work in May at our quality symposium, as well as at the conference in September. So highly encourage you all to do that. It's really easy. It's a lot of fun. And what you'll hear from Jay today, make sure you put Shewhart Charts in your posters. So anyway, with that, I'm going to go ahead and pass it to Jay. Thank you, Jay, for attending with us, and I'll let you take it away.
All right. Well, thanks for having me. And I want the whole enchilada here. Let's see if this works this time. Okay, you should be able to see my Shewhart chart presentation.
We do. We
All
do.
Right. Okay, so we're just going to touch on a few things just to give you some idea. I've been working with healthcare for over 25 years. Back in 1999, when To Err is to Human came out, the Joint Commission asked anybody who wanted to be certified as a Joint Commission hospital to draw all of their core measures as control charts. And there was some email listserv out there, and nurses would write in and go, how do I draw a control chart? And 5 nurses would write back and say, by QI macros. So this was, 25, 26 years ago. So that's how I've gotten involved with healthcare across the nation over the last 20 some odd years. QI macros are used in about 3,000 hospitals nationwide, so I get a chance to see lots of things. Now, one of the things every year I do is I go to the Magnet conference, and at Magnet, to get a Magnet designation, which you all should be familiar with, you have to do like 200 improvement posters. Well, guess what? I do this thing. I walk around and I wanted some data. So back in 2015, I started gathering data about who's using what kind of chart. And anytime you see a poster presentation, I'd go, well, if there's a bar chart, I'd make a stroke tally, or a line chart, I'd make a stroke tally. Whatever else I found on there, I would make just a little stroke tally. So it turns out that bar charts and line charts and pie charts are 90% of the poster charts shown in posters at Magnet. Now, I consider these to be the three stooges of charts. They just won't tell you enough to be able to achieve zero harm. So what we want to do is move on and start using these 100-year-old Shewhart charts. At the Institute for Healthcare Improvement this year, it was mainly bar and line charts, about 2/3. And down here you can see, I think there was 2 control charts, 3 histograms, some Paretos. And I was in one presentation that was about Shewhart charts and stuff like that. And Dr. Lloyd Provost was there, who's the author of the Healthcare Data Guide, co-author. And he said, well, I've been teaching statistical process control all over the world for the last 30 years. And so I have to ask, why is there only 2 control charts in all of the posters that are out there? Now, I believe that you can't get to zero harm or really high levels of performance without them. If you look in manufacturing, those people don't even question it. They just do it, right? Because otherwise they would not be in business. So I'll just touch on a few things. Here's my key 3 things, right? There's 3 types of main data that I look for. So there's time series. So over time, this one's by month or something, falls per 1,000 patient days, ratios, VAP rate, anything you want to name, C-section rate, any of those things could be plotted this way. Denied insurance claims, that's money. You can plot time this way. And you're going to want to use a control chart. And Dr. Donald Wheeler says the XMR chart is the Swiss Army knife of control charts. So you don't need to learn 1,000 charts, right? You just need to learn this one and really get good at that. And then you can move on into the other charts. Now, Provost and Murray really like P and U charts. And I think those sometimes can be confusing to people. So I caution and just say, I think master one chart and then move from there. And then we want to count things, mistakes and errors, medication errors, repeat radiology reports, anybody who, comes back, Medicare people that come back within 30 days, right? So those are the kinds of things we could count. So here in pharmacy, here's order entry errors. Now we can take a line and a bar chart and put them together in an intelligent way, and we get a Pareto chart. And I find the Pareto chart is the power tool for diagnosing and treating crazy stuff, that can happen in healthcare. And the funny thing about it is every hospital is sick in its own way in terms of being sluggish and error prone, and they're all designed differently. And so they're like patients. They're a little bit different. And so what we have to do is use these tools to really be able to diagnose and treat what's going wrong. And so let me ask, and I forgot to do histograms, sorry. So why do we want to use control charts for evidence-based practice? Well, in Magnet, that's kind of the key focus. Well, here's a nice line graph, but without a control chart, you can't tell if there's any unstable conditions or trends or whatever. And so the software, QI Macros, will calculate all that. It'll help you pick what chart to choose. It'll identify all of the improvement, rules, control chart rules that are out there, and give you some insight. So here's a chart that I found at one conference. And I can't tell you how many people I see taking pictures of these like they're going to go back to their hospital and implement it and waste a lot of time and energy and money. So here's Cowdy's, and here's a trend line. But I want you to get an idea that these trend lines are fake news. Fake news. Because almost nobody puts an R squared or goodness of fit metric on here. So it turns out this is only a 30% fit. And if we show that as a control chart, you can see we have one out of control point, and then there's one nice stable process here. So we have a stable process. Nothing improved. I'm sorry. Right? But I see this all too often. Here's C diff, and here's another downward trend. And here you can see our goodness of fit is a little bit better than 50%. 80% is considered good, right? But 50%, we're starting to see something going on. But if I drew that as a control chart, I would quickly discover that there was a before and an after. So we went from about 9 a month down to 5 a month. So that's a good improvement. This is the kind of story that I think you want to tell when you're showing improvements. If the process don't change, then you didn't get anything. And I think people forget that that's part of our problem. So anyway, I think, you've got QI macros, so you have charts that went to college and took statistics so that you don't have to. So control charts and Pareto charts and histograms, and these will help you really diagnose and tell a great improvement story in your projects, your posters, your presentations. For over a decade, I've gotten the Joint Commission's Journal on Healthcare Quality. I think that's it. And I so rarely see a control chart, a Pareto chart, or histogram in there. I see lots of spreadsheets. And let me be clear, nobody wants to read your spreadsheet, right? And they don't want to look at your line graph that has, 10 lines on it. They can't figure it out. You can figure it out, but they can't. So what do we want to do? Start to move up into the tools that will actually make a difference. And so I think using line and bar charts means you're saying no to zero harm. And one more type of chart out here is time series. So radiology repeat, turnaround times, time to thrombolytics. All of these things can be done as a control chart and also as a histogram. So what we want to do is slide that histogram towards zero. Nobody wants to wait for care. Nobody wants to wait for things. Nobody wants to wait for diagnosis and treatment and results and all those things. How do we squash that down to zero? So anyway, here's some things like, here's an XMR of falls per 1,000 patient days, showing a process change. We could also have drawn that as a U chart, falls per 1,000 patient days. And here you can see there was actually a process change. One of the things Donald Wheeler says is that P and U charts tend to have too many things where they treat them as special causes. This is the same data. You notice on the X chart, we're using the actual data about ratios about falls. And so the limits are all calculated based on the data. In U charts, here you can see these are all based on theoretical limits, and they tend to cause you to notice more potentially special causes. So we love XMR because it doesn't trigger all kinds of crazy activity, but Provost and Murray really like them because they do. So this is the battle of statisticians. I have found there are battles of statisticians. Who's the one guy? There was one famous statistician, and he said, what's the plural noun of statistician? He said he thought it should be a quarrel of statisticians. So just be aware that you're not always going to get the same answer from people when you ask them. You're going to get slightly different answers depending on their point of view. And here's a histogram of time to thrombolytics. You could also here's one where I took all of the charges for deliveries and put all of the doctors side by side. And so you can see one has a lot more variation. Another one has a lot less variation. And here you can see one's kind of got crazy variation. the funny thing about this, you know, if you show data to doctors, they will spontaneously self-correct to bring themselves in an alignment with overall performance. So you don't have to do anything except say, look, Dr. 11, you know, you're kind of getting wild and crazy here. What's that all about? So anyway, those are my 3 tools: control charts, Pareto charts. You can show before and afters and before and after histograms. And QI macros will automate the creation of all of that stuff. And here's what I think a world-class improvement poster should look like. Control chart, maybe a couple of levels of Paretos, fish bones, and so on. Now, if you go out to our website, qimacros.com, we have lots of free training out here. All right, so if you come down to our free Agile Lean Six Sigma trainer training, and you scroll down the page here, you'll see that at the bottom, you can download a free copy of my Agile Process Innovation book, the stuff I use to train people, and my improvement prescription. So here's the latest version of this book about how to hack Lean and Six Sigma to maximize your results. There's my training document. And then here's our quality improvement prescription. And this is a 1-page cheat sheet about how to hack Lean and Six Sigma to start getting results quickly. So those are all out on the website. And you may know that there is lots of free QI macros training videos out here. So there's a Teach Yourself QI macros workshop. So this is a self-paced 1-hour workshop to learn how to use QI macros. If you want to know how to use anything we have out here, like the control chart wizard, all of these are videos about how to use various things on the QI macros. All right. So you can watch these anytime you want, day or night, 24/7, 365, as long as your internet's up and our website is up. So I just wanted to get you on the idea that we have all this free training. You might as well avail yourself of it. And then I do webinars just about every month. If you come under free resources and come down to our Improvement Insights blog, you'll see that yesterday I did a healthcare data analytics webinar, and you can watch that. And if you want to get my free videos, you can sign up for that. And, you know, they're like 3 minutes to try and trigger some thinking that's useful about quality improvement based on things I've learned over the years. So that was a high-speed tour of some things. I think, does that help? And it's now a good time to start talking.
Yeah, Jay, great overview. I wonder if you can just really quickly, I would love for you to show the, oh, hold on. It's called, you've got it called the Improvement Project Wizard.
Okay.
Yeah. Would you just give a quick demo of that?
Well, sure. Remember, I showed you that the poster. Let me get over here. Yeah, there we go. And I think that improvement projects should look like this. So we're going to do some analysis and then fishbone diagrams, countermeasures, measure your before and after. So years ago, I started doing some improvement projects, and I found it was most useful to sometimes I had to take data like this, which was by date, by nursing unit, type of patient harm. I did one with healthcare denied insurance claims. So here's by hospital admit date, type of denied charges. So these things, this is where the big money lives. You know, if you want to find multi-million-dollar projects, it looks like this. And it might be in your medical record systems or your purchasing or your payments or your accounting systems. Every company I meet is awash in data, but they just don't know how to pull it out and analyze it. So what I had to do was actually you do things like insert pivot tables and then turn what I got out into control charts and Pareto charts and whatever. But back in 2017, 16 and 17, I invented the Improvement Project Wizard to automate all that. So sometimes people ask me about if we have artificial intelligence in QI macros. Well, we don't have machine learning, but this is programmatic AI. I've taken what I know how to do and automated it. So you can click any two headings and click on this Improvement Project Wizard. And the Improvement Project Wizard will pivot that data, look for control charts, and then it's going to look for like high level, what I call the 80-20 level Pareto chart. Then it'll drill down into the big bar of that and say, what's the next level down, what I call the 450 rule Pareto. And then it'll create a fishbone diagram. And then when it's all done, it'll come back with a executive summary. Now, what it just did in a matter of minutes used to take me hours and sometimes days. And now I just pick a couple of headings, click on the Improvement Project Wizard, walk away, get a cup of coffee, and come back, depending on how many columns there are. So it found a control chart, and then it found two projects. And so within those projects, there's a high level 80-20 level rule Pareto. But I've usually found that those are too broad to be able to do good root cause analysis. So it takes the big bar and sees if it can drill down a little bit. And once you drill down a little bit, you get a 450 rule. As little as 4% of what you're doing is producing over half the mistakes, errors, waste, rework, lost profit, patient harm, whatever you wanted to call it. And then it'll create a fishbone diagram off of that with a problem statement. And it does that for additional. It keeps looking. It's looking for the best project it can find. So it did a pivot table, and here's our patient harm by date, 8.5. And according to the IHI, one patient out of every two suffers some sort of preventable harm while in a hospital. 1 out of every 2. That's way below one sigma. All right, so there's tremendous opportunity. And then here you can see nursing unit. Well, it turns out that nursing unit 3 has most of the patient harm. And then I drill down into that. And it turns out that patient falls is almost 40% of unit 3 falls. And then it'll build a problem statement and a fishbone. So now you're ready to start doing some improvement. But it doesn't really stop there. It starts going in by type of patient harm. So patient falls, nausea, and rash were 2/3 of the total. And so patient harms are big bar. It's going to drill down into that one. And so here we can see unit 3 has 79% of the total. And that gives us a fishbone diagram. Now, I was at one conference and exhibiting, and the nurse I was talking to said, oh, yeah, that's exactly what we found. It was men between the ages of 20 and 40 in the orthopedic recovery unit who were falling most of the time. Now, I want you to get this idea that once you've done this analysis, you can now figure out who should be on your team. Beforehand, you will not know who should be on your team, right? We want to drill down, narrow it down, because now we know I need people in Unit 3 who know something about patient falls. And I don't need anybody from Unit 1 or 2. I don't, anytime you spread that out, you start to get confusion, because the problem in Nursing Unit 1 may not be the same problem as in Nursing Unit 3. So I want you to get this idea that this is the idea. And here's one of our pivot tables that came off of our nursing unit data. So it took all this data, and I've done this with, tens of thousands of rows and as little as a few hundred rows. And it's amazing what kind of projects it'll pony up for you. So that's the Improvement Project Wizard. Sits right up here. And we have all kinds of wizards: control chart wizard, chart wizard. We have a templates wizard. We have a stat wizard. All of these things are designed to automate analysis and make things a lot easier and faster. That help, Ryan?
That was perfect. That was perfect. So yeah, we use, most of us here at Stanford, if they go through any of our training programs, you know this, Jay, use QI macros
Right.
for all this work. There were some features though that you just showed me this week that I hadn't seen that one included. That was pretty awesome. And several people were like, wow, that was incredible. Maggie says that was indeed wizardry. Yeah, it was pretty nice.
Yeah.
So certainly for all of us, when we're looking to do improvement work or we're trying to understand where we should even start, this might be a great tool to use to really be able to help us. The
Right.
let me open it up to questions from everyone else. I know there's probably people who've got questions and want to pick your brain, so I'll open it up. This is not a shy group. Okay, Hurley, go ahead. Of course, Hurley
Jay, it's
wants
nice
to
to meet
jump
you.
in.
Thank you so much for being here with us. You may not be able to tell, but you're a bit of a legend to many of us.
Yay.
We don't have the viewpoint that you do, getting to visit so many different hospitals, and you're going to all these different conferences. But your point resonates about how, look, these things are not overly complicated. They're pretty
No.
straightforward concepts, and you're preaching to the converted with us. Yet, you said, in your talk that hardly anybody's really doing this. You said you went to a magnet conference and saw like 2 control charts. And so my question to you, Jay, is what's your take on that? Why is the healthcare industry so slow to get on the up and up with these things? And I would take it a step further and say that most of us on this call have observed hospitals go through the excitement of, oh my gosh, we're going on an improvement journey. We're going to be this, we're going to be that. And then a few years later, it's like they dissolve the team, they forgot it, and it's all of a sudden no longer shiny to them. So I don't know. I'm curious, like, where are we at as an industry? Are we picking up this stuff more so, or are we still laggards?
Lagging.
Yeah.
Now, why do I say that? So I went off Zoom so I could see everybody. So 2 things. Number one, my first one is that during, I lived through all the process improvement adventures in 2000 and 2010 and ongoing. And one of the big problems was they brought in people to train who were based in manufacturing. They were manufacturing trainers. And there's a whole lot of stuff in manufacturing that healthcare don't need to know, right? So I say there's the magnificent 7 tools, right? So pivot tables, control charts, Pareto charts, fishbones, histograms, countermeasures, matrices, and value stream mapping, and so on. And those will solve most of the problems facing you all. So I argue for minimum viable training, which is what that Agile book will tell you how to do. So number one, I think that was a problem. And then people had a hard time transferring what they learned from a manufacturing environment into a healthcare environment. So when I teach, I always use the data, that sample data that's in QI macros. I created all that sample data so that when I'm training healthcare people, I can use healthcare data. And I put the healthcare data guide data in there as well, so that people can see how these things can go forward. And even if you go to our website and type in qimacros.com/HCDG for healthcare data guide, you'll come up with videos about all of those. So I believe, number one, the people who were training failed healthcare because they tried to teach what's manufacturing. A friend of mine worked for GE Healthcare, and she said they have us teach black belts 3 days of design of experiments training. She said, which they will never use. Never use. Now, here's one of the things I want you to think about this from a lean perspective. If you try and stuff too much stuff into people's noggin, that's called overproduction, right? If you're stuffing too much stuff in there. And so what happens, and I can tell you from long experience, people will call up and they'll tell me, well, I'm a black belt and I'm a green belt or I'm a blah, 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 but they have no freaking clue about how to get started. And I'm going, you want all this training? You don't know how to get started? And I think that's because there's too much stuff in their brain. So minimum viable training, 7 tools, QI macros, and you can make a lot of headway. Christus Health rediscovered this probably 4 or 5 years ago. Novartis, Underwriters Laboratories, Crayola are chasing a faster, better, easier way of training and not teaching everybody everything, because I think that's a waste of time. So that's one piece. The other thing I've found universally is that when people are hired to do training, they do not ensure that the participants get software. Doesn't matter if it's QI macros or Minitab or whatever it is, they don't get tools to be able to do the job when they go back. So, it's like teaching an auto mechanic, but you don't give them any wrenches or screwdrivers. I just think that's insane. So that's another problem. And then it's so easy to use line and bar charts in Excel or Google Sheets or whatever it is. Some companies have done away with Microsoft Office and only have Google Sheets. Well, you're kind of stuck if you do that. So there are many things, barriers in the way, and partially quality people created it. I just think humans don't want to go to their boss and say, hey, I need, $400 to buy some software to do my job. When I first got trained in 1990, the Florida Power and Light people said, hey, there's this product out there you can buy. It's $1,000. I think it was Minitab. They didn't tell me what it was. And I went to my boss and I said, hey, there's this product out here that'll draw these charts that's taking me forever to draw, and it's $1,000. He said, we just sent you to training. Go back and do your job. That is exactly what he said. And I think a lot of people hear that message and go, okay, well, I'll just go back and do my job. So I gave you about 3 different big reasons. Those are my biggies. And I also think most people just don't know how to go about it. I think it's super easy. I do have the free yellow belt training online. So under our free training, there's a yellow belt training anybody can take anywhere, anytime. And it's free for veterans. We charge $95 for people who want to take the test and get certified. That's just for, processing fee, basically. So I think, I'm trying to make it easy for everybody to learn. Sorry, that was a long answer to a short question.
No, that was a great answer. Thank you, Jay.
It's great. Jay, there's a question in the chat. This is kind of funny. I like it. Who would you consider to be, I'm going to alter this slightly, but he says the Demings of healthcare improvement. I would say like the pioneers of improvement for healthcare. Yeah, Hurley. Yeah, besides me, of course, right. Yeah, not even. So.
Well, there's someone that I've worked with for years. She hasn't really published about it. Is Deborah Smith, right? We met.
Yeah.
But the problem is, Deming and Duran were mainly manufacturing, and Deming, they didn't listen to him, so he went off and helped Japan create great cars. And then eventually Ford and everybody said, hey, maybe we ought to get this guy in to help us out. But that was still all manufacturing. And then Motorola came up with the whole Six Sigma idea and started to roll that out in the end of the 80s, but that was still about manufacturing. And it wasn't really about healthcare. And so I would say there aren't many, other than me ranting, in the dark, right? The old men of quality have died. They're gone. That was last century quality. This century quality is about service industries. 80% of America works in service industries, not in manufacturing. Less than 10% work in manufacturing. And just a tiny fraction of those actually work on a production line where you can use all the crap that we teach in Six Sigma. So, that's why I, wrote the book, Lean Six Sigma for Hospitals. These are kind of my learnings. And then a surprising number of people come up to me at these conferences and they go, gee, Jay, I took this training and then I read your book and then I understood what they were trying to teach. I think there aren't many that I know of. Maybe you do, but I just don't know many.
So thanks. Other questions? And Richard, I see the eye roll on there. Yeah.
That was a mistake,
No
Corey.
respect.
Yeah, I just hit that by mistake.
Sure.
And it was really meant for Hurley, not for you.
Okay.
I thought you said it was a mistake. Now it was for me?
No, it was for you.
Yeah.
It wasn't for him.
Targeted. Oh boy. All right, so let's see. Okay, so Rachel says, how often do you encounter teams using these tools but are using them to measure the wrong things?
Almost never, because I don't let them. However, I will tell you, back when I was in the phone company, the people who ran the outside repair and installation services and all that kind of stuff wanted to prove that they needed more people to handle repair. And they talked to our quality consultants into dreaming up data to support that. And I got put on a project to go work on this. And I was there for like 1 day in Salt Lake City. It took like 2 months. I was gone every week for 2 months. And I looked at it and I said, we don't need more repair people. We need fewer, less repair, right? We don't need to have what causes things to go down. And let's prevent that. So in Seattle, it was too rainy, and in Arizona, it's too hot, right? All of these things cause certain kinds of behaviors in the local network that cause things to not work. And I went back to my VEEP and said, this is dumb. We need less repair. And they said, well, it's already gone down this path. So I would say, number one, beware of someone who has a pet answer and wants data to prove that their pet answer is correct. And this is ongoing. Another thing at the phone company, they decided, well, we need new call centers to redirect all the calls to our 9,000 service reps. And they spent $12 million on that. And guess what? Wait times did not change 1 nanosecond. Right? So people can get caught up in wanting to prove a solution rather than letting the data lead them to the problem that can be solved. And so I see that occasionally. And then there's also people who don't like what they're seeing because it might make them look stupid. People have this fear of looking bad, right? As opposed to going, oh, here's my data, help me, right? They're like, I can't show you my data because you might find something I can't see, right? That we helped save $5 million in denied insurance claims, and those people had worked on that project for a year. I diagnosed it in about 3 or 4 days. We figured out how to fix it in an afternoon and implemented it on a Monday and started saving $400,000 a month. Is everybody willing to show you their data? No. So just be cautious. And one other thing is realize that all of your data is systematically distorted to make someone look good. The good news is it's systematically distorted. Ergo, you can use it because it's been systematically distorted. So I never worry about, is the data correct or anything. It is the data that it is, and let's work on that. So long answer to another short question.
Okay, so a couple of quick questions. I don't know if Hurley's is a real question.
It's real. No one asked that. It's real.
Okay, all right. Hold on. Well, I'll Well, let's start with that one, and then we'll go to Tobias. All right. So is Pareto's Big Bar a real place, or at least modeled after a real place?
According to Ryan, yes. It's not a real place, though. He just called it that. Every month, Ryan on my staff writes an e-zine story about something, and usually it happens at Pareto's Big Bar, right? It's not the big bar in the Pareto charts, but they drink there. And so, no, not a real place, but it's modeled after some place that Ryan has in his brain. So
that's good.
Different Ryan, I figured out.
Yeah, not me.
So here's
okay,
one.
Tobias' question is about the improvement project wizard, wondering what sort of Excel cell data formats are not compatible with it. He says, for example, it looks like data source from multi-select field cannot be analyzed successfully by the wizard.
Yeah, so all too often people try and cram multiple things into one cell. You need to split those out into separate cells to be able to analyze them. But Excel has a tool to pick and split those out in delimited columns. So yeah, I would not, if you're packing stuff into one cell, you have to split it out to make that work properly. That's true of any pivot table.
All right, last question, and then we'll split for a few minutes for the last few minutes. What are the most common misuses you see of statistical process control, and how can we avoid those, particularly to healthcare?
Well, since nobody's using it, I haven't seen anybody misuse it.
A good answer. That's a good place to stop.
Well,
okay.
You know, I think all too often people. So I've seen a presentation. There was one in 2023. So they started off and they had a baseline, and then they reduced their happy rate, and then they reduced it some more, but they forgot to show the next process change. So they could have really shown a dramatic improvement. After the fact, they did another improvement, but failed to show it. That's not misuse, but I think they missed an opportunity.
Meets over at Stanford Health.
Yeah. So one of the things I'll offer to all of you, if you want help, right, just reach out to us. Reach out to j@qimacros.com. Click on our support button down there, chat in. If you want us to look at your data and help you think about how you might present it or anything like that, feel free, right? I want you all to be wickedly successful and make all these other people look foolish and really raise the bar. One of the things I've been arguing with IHI is I think that they should require control charts, Pareto charts, and histograms and fishbones in their poster presentations, or you should not get on the wall. And I've been arguing that now for about 8 years, but nobody listens to me because I'm just a consultant and a supplier. So sorry.
No, it's great. No, it's perfectly good. That's why we have you here. And so this has been wonderful. This has been really good. The feedback I'm seeing is great. What I would like to do is usually we end with we have our breakouts, and then we have I wish, I wonder. I'm going to forego the immediate feedback just to allow you to, everyone, I'm going to break you all out into rooms. Hang out as long as you want, but this is going to end the formal part of this session. And from here on forward, you can hang with the people, you can get to know them, connect, or you can bail, whatever you'd like. So I'm going to do that. Thank you all for your time. Thank you, Jay. This has been wonderful. And please reach out to Jay, reach out to me, reach out to Hurley, any of the improvement team to help you along your journey as well. So excellent.